Right. Hi, I'm Jessie,
And I'm Megan.
and we're going to be going over diabetes insipidus. So, first of all, Megan's going to tell us a little bit about what it is.
Okay, thanks, Jessie. So, diabetes insipidus is an endocrine disorder that is caused by the deficiency of production or secretion of ADH or the decreased renal response to ADH. So, ADH is antidiuretic hormone and it controls the fluid retention and the electrolyte reabsorption in the body. So, because DI involves the inadequate production or inadequate response to ADH, DI causes afluid and electrolyte imbalance in the patient's body. So there are three types. Central is where the problem occurs in the brain. This is where there is an interference with the synthesis, transport, or release of ADH. Some examples of when this might occur could be if somebody has a brain tumor that's affecting the glands in the brain that release ADH, or if there is a head injury that did something similar. Nephrogenic is the problem occurs in the kidneys. So there is a decreased renal response to ADH, despite there being an adequate amount of ADH in the patient's system. Some examples of when this could occur would be if the patient has renal damage or certain types of drug therapy can cause this to happen. And then primary is when there is a large amount of fluid intake. So this could happen if there is a lesion in the thirst center in the patient, causing them to take in large amounts of water because they feel like they're thirsty all the time, or if they have a psychological disorder. Out of those three types, central is the most common form of diabetes insipidus. And then depending on the underlying cause of the disease, diabetes insipidus can be an acute or a chronic disease. So now Jessie is going to tell us a little bit about the signs and symptoms of diabetes insipidus.
Perfect. Thanks, Megan. So, some signs and symptoms that you're commonly going to look out for. The most common ones are going to be polyuria and polydyspia for your patients with diabetes insipidus. So, what that means is polyuria is that the patient's excreting large amounts of urine. So, they're going to the restroom all the time, many times throughout the day. And that's because the ADH is either low in their system or they're not responding to ADH, which is an antidiuretic hormone, and tells the patient's body to hold on to that water and excrete less urine. Because they are constantly excreting water and getting rid of fluid, they're dehydrated, and so their body, which signals the body to experience polydyspia, which is excessive thirst. So they're asking for a lot of water, drinking a lot of fluids, and yet nothing's quenching their thirst because their intake isn't matching up with what they're excreting. They also can experience large amounts of urination throughout the night, which is called nocturia. And so because of that, they're getting up and going to the restroom. They're having interrupted sleep. And so they're going to experience a lot of tiredness, overall lethargy, exhaustion, weakness, symptoms like that. They're also going to have an increased serum osmolarity and hypernatremia because they're excreting lots of water loss and holding on to sodium and other nutrients such as that. The patient's going to experience other symptoms if it becomes more severe dehydration, such as hypotension, tachycardia, which is an increased heart rate, or even signs and symptoms type of volemic shock, such as pale skin, shakiness, sweatingness, or CNS manifestations such as mood alteration, or level of consciousness could be altered, or they could even go into a coma. So it's really important as a nurse to understand what those earlier signs and symptoms are and catch diabetes insipidus early so that you can create a treatment plan before it progresses to some of these more severe manifestations. So now that you know a little bit about the signs and symptoms, Megan's going to go over what diagnostic tests you can tell to, if you see these things, to tell if your patient does have diabetes insipidus.
Okay, so if your patient presents with any of those signs and symptoms, you're going to want to run some tests in order to determine if it is diabetes insipidus. A 24-hour urine volume analysis is usually done to determine the amount of urine that's being excreted, as well as the rate and the concentration of the urine. So it's usually considered diabetes insipidus if the urine is being excreted at a rate of greater than 200 milliliters an hour, and the specific gravity of that urine is less than 1.005, which is considered very dilute. So after the diagnosis of DI, you're going to want to do some tests to determine if the cause is central or if it's nephrogenic. Water deprivation test is usually done to diagnose central DI. So this is where the patient is deprived of water for about 8 to 12 hours and then given a hormone like desmopressin, and then they look at the changes in the osmolarity of the urine, and depending on those changes, they diagnose if it's central or not. ADH level tests can also be used to determine if it's nephrogenic. So the patient is given an analog of ADH, and then they relook at the concentration of the urine. If the urine remains dilute, then it tells you that the kidney's not responding to that analog of ADH, so the problem is most likely nephrogenic. After determining if the problem is central or nephrogenic, then usually imaging tests are done to determine the source of the problem. So for example, if the patient is diagnosed with central DI, you might want to do an MRI of the brain to see if there's a brain tumor or anything going on in there. And if the patient is diagnosed with nephrogenic, scans of the kidney to look at if there's any damage to the kidney is really important to find out why that problem is happening. So that's the diagnosis criteria. Now Jesse's going to tell us a little bit about how to treat DI.
Perfect. So as Megan said, there are different types of DI, and so it really depends on what type of DI you're trying to treat as to what your treatment plan is going to be. So for diabetes insipidus central DI, which is the most common type, as Megan told us, their fluid replacement and hormonal antidiuretic hormone replacement is the main course of therapy. So a lot of times for more acute cases or less severe cases, you can have the patient just increase their fluid intake, and that can be enough, just the oral fluid intake increase. However, you also might need to give IV infusion therapy with a hypotonic saline or a 5% dextrose in water, which are both hypotonic solutions if it is more severe dehydration. You want to use a hypotonic solution because the patient is already excreting a lot of water and holding on to nutrients, and so they're in a hypertonic state, and so you want to give that hypovolemic or hypotonic solution to bring them to a more isotonic state in the middle. You also want to replace with hormone therapy, which there's two analogs of the antidiuretic hormone, DDAVP, or also known as desmopressin, which is the most common one, or aqueous vasopressin. So desmopressin or DDAVP is the most common one used because there's a lot of different treatment options. It can be given orally, subcutaneously, intranasally as a spray even, or IV for immediate treatment if for something more severe. However, if that's not available or the patient has any contradictions with DDAVP, you can also use aqueous vasopressin as another analog. Those are more the treatment options, and then you can also potentially prescribe the patient clopramide or carbamazepine because those will help treat the symptom of excessive thirst. So while they're not treating potentially the water loss directly, it will help minimize that symptom of excessive thirst for the patient. For nephrogenic DI, however, the treatment's a little bit different because that analog therapy isn't going to help since the patient's body wouldn't be responsive to it anyways. So for them, we focus more on diet modification and other medications that can help decrease the urine output. So you want to make sure your patients are on a low sodium diet, below 3 grams per day. And then that's really important because as the low sodium diet is going to decrease the urine output for the patient and decrease the osmolarity. Thiazide diuretics seem a little bit contraindicated at first since you're giving a diuretic to decrease urination. However, studies have shown that they've been really helpful in treating actually chronic long-term nephrogenic DI. And it's holding on to that sodium and it's increasing the sodium intake in your body, and then it's decreasing the urine output. You can also be prescribed indomethacin, which is an NSAID, if that treatment isn't enough alone, and that increases the body's response to their own ADH hormone. So now that we went over a couple of treatment options, Megan's going to go over some other nursing interventions that you can do to help these patients.
All right, so as Jesse mentioned, early detection is very important to improve patient outcomes. So the earlier you pick up on these signs and symptoms and the earlier you treat the patient, the better outcomes the patient is going to have. It's also very important to maintain adequate hydration because DI can cause that large fluid loss. So this includes the IV replacement therapy, like Jesse mentioned, and then this also includes frequent assessment for signs of dehydration. So making sure you're frequently assessing the patient for that so you can stay on top of their dehydration. The nurse should also be monitoring vitals and labs. So blood pressure and heart rate are important to monitor because they can show signs of changes in the patient's fluid volume status. And then urine-specific gravity should also be monitored because it shows the concentration of the urine, which can help you determine the patient's current condition. All of these vitals and labs can be monitored as frequently as 1 hour, depending on how severe the patient's condition is. And then in terms of recording things, the nurse should be recording intake and output very closely. This can also give you an indication of patient's fluid volume status as well as daily weight. So the patient should be weighed at the same time each day under the same circumstances to make sure you're getting those accurate daily weights and recording so you know the patient's fluid volume status. And in some cases, the patient may have a chronic form of DI and will be living with this disease. So in that case, the nurse is responsible for patient education, educating them on their disease and some long-term management options for them. So those are some interventions. Jesse's going to tell us a little bit about that education piece that you would talk to your patients about if they have DI.
Yeah. So as Megan said, for chronic DI or long-term DI, this is something that it's important to let our patients know that they're going to need constant treatment for throughout their lifetime or maybe over a long period of time. So as she said, monitoring strict I's and O's during acute care is really important. It's also important for them to do that when they go home as well, potentially depending on how severe their DI is. They're also going to want to regularly check their blood pressure at home because changes can show if they're returning to dehydration status. And also, if it's for long-term nephrogenic DI, it's important for them to follow that strict low-sodium diet that we talked about. They also want to continue those daily weights once they go home. And so to tell your patient to weigh themselves every morning without their clothes on at the same scale around the same time of day, and then to report to their provider any changes that are greater, that are gaining or losing more than 5 pounds within a week. That's kind of their bar that they're looking for. And then lifetime management of nephrogenic DI is needed. And so it's important to let your patients know to take their medications regularly as prescribed and to not stop them without speaking to their provider first or just stop them abruptly because they feel better. It's also really important to let your patients know when they need to call their provider and what signs and symptoms to look out for if it's getting worse or things that might be more concerning. So when to call your provider is if you feel dizzy, if you feel faint, if you have constant low blood pressure readings when you're monitoring your blood pressure, if you're having that weight gain or weight loss that's more than 5 pounds, as we talked about, if you have tachycardia, so if you're feels like your heart is pounding or you have a really rapid pulse rate, if you're able to check your pulse. And then it's also really important to report if you have any anxiety, thirst, cool, clammy skin, or oliguria, which is no urination at all, because all of those can be signs of hypovolemic shock, which is really important to get treated right away. It's also really important to tell your provider if your symptoms of thirst and constant urination or polyuria return or continue even though you're on treatment, because your treatment might need to be adjusted slightly or your medication regimen or doses adjusted. So those are all really important to talk to your provider about if you experience any of those things. And here are some important references that you can look at for more information on diabetes insipidus, and if you want to look into any of this information further.
So thank you very much for watching. This has been our presentation on diabetes insipidus.